Good morning, everyone. It's a pleasure to be here and to talk to you about pharmacogenetics. I think it fits very nicely in the excellent presentations that we have already seen this morning. I think pharmacogenetics is a little bit closer also to patient application, but then again, we can improve it very much by using all of the great science and technologies that were presented earlier. So, why pharmacogenetics? Well, this cartoon more or less illustrates the problem. Drugs are the most frequently applied medical intervention. I'm a clinical pharmacist and pharmacologist. I work with them. I'm very happy with them. They work, but they do not work for all the patients. And on top of that, they also do cause adverse drug reactions, which may seem trivial, but is very important because over time, data consistently and repeatedly shows that 6 to 7% of all hospital admissions, in fact, is drug-related and caused by adverse drug reactions. And I think that by using genetic information, we can really improve these numbers. And this concept of pharmacogenetics, before you prescribe a drug or use a drug, you use a DNA test. That is very easy, in fact. And based on the test results, you can either then adjust the dose or maybe select a different treatment. Very straightforward, very clean, very easily thought of, and this has been around as a promise for a very long time. It was already proposed right at the beginning of the 20th century, so way more than 100 years back, by this person, Sir Archibald Garrett, but that is also part of the problem, because it has been around as a promise for so long, people still think of it as a promise. And let me tell you, it is also a practice today. And I think in the recent years, also with this project that I've been working on, it was sponsored by the European Union, Ubiquitous Pharmacogenomics, we've made a major step forwards to clinical application. So let me first give you two examples. The first example is about one drug and one gene, actually. And it's about the drugs that have been around for 50 years, I think, 5-FU and its oral prodrug capecitabine. These are widely used anti-cancer drugs. They're part of the treatment regimen for colorectal cancer, breast cancer, esophageal cancer, many different types of cancers. And these drugs work, but again, they have this problem of a severe adverse drug reaction. So 10 to 30% of the people treated with these drugs develop adverse drug reactions that require hospitalization. And maybe more importantly, 0.5 to 1% of the people die actually of the treatment and not of the cancer. It is known that genetic variants in a gene called DPYD are associated with increased toxicity risk. And you can see here, the pharmacokinetic pathway of these drugs. So this is the oral prodrug. Once you swallow it, it is converted into 5-FU. Some of it is excreted by urine, but the majority of it is converted in inactive metabolites by an enzyme called DPD. And a small fraction is converted into active metabolites, which then attack the cancer, but also cause the toxicity. And when you have this genetic variant in DPYD, you don't have active DPD, and you have a much higher risk of this toxicity. So this was known actually for 25 years or something, but a couple of years ago in the Netherlands, we said, okay, we have now this knowledge, we should use this, we started using it, and we designed something. It was a collaborative project of multiple hospitals in the Netherlands, so the Erasmus Medical Center, Leiden University Medical Center, and the Dutch Cancer Institute, and we did a prospective study with 17 hospitals where patients who were about to start with capecitabine or 5-FU were tested for 4 genetic variants in DPYD. And if they carried one of these variants, they received a 50% dose reduction if they carried these two, or a 25% dose reduction. And what you can see here in the slide is the risk for toxicity compared to historical controls in red, and green dots indicate the people with the variants. And what you can see is that by running this test, compared to historical controls, we could reduce the risk for this severe fluoropyrimidine-related toxicity from 2.9 to 1.3. So this is quite a large reduction, and if I were to be treated with these drugs, I would want to know my genetic test result before taking them. On top of that, we also showed that no patients died anymore of the treatment. Also very important. And very importantly, we showed by following these patients for more than 10 years, we showed that progression-free survival and overall survival were not negatively impacted by reducing the dose. Because otherwise you could, of course, say, okay, you test patients, in some of them you reduce the dose, of course there you see less toxicity. If you don't give them any drug at all, you see no toxicity. But then of course the drug doesn't work. So this is very good. Based on these results actually, and that's why I want to include this example, some of the researchers in our group made an appeal with the regulatory agencies in Europe, the EMA, EMA took this into consideration, and in 2020, April 2020, they actually changed the label of capecitabine and 5-FU to include a statement that you should either do a genetic test for DPD deficiency or you should do a enzymatic test. And why is this important? Well, during our study in the Netherlands, this test became more or less routine practice. All patients were tested. This was not the case in Europe. When EMA released this statement, you could quickly see that the uptake of this test in European countries increased enormously. So this is the result of a survey 1 year before and 1 year after the EMA recommendation, and it shows that after this recommendation, in the first year alone already, there was an increase of 76% in uptake of this test. And mind you, it's not a mandatory test, it's a recommended test. It's not mandatory because if it would be mandatory and you wouldn't do it, then you would make a prescription error and you would be liable. So it's only a mandatory test, but it's only a suggested test, and that alone has this enormous effect. So that is one drug, one gene. You've seen all these talks about fascinating, large genetic studies, so why just test 4 variants in one gene? Why not expand and do a panel test at once? There's actually quite some evidence for that, because for multiple different drugs, and I think it's around 30 to 50 different drugs, we have quite good evidence that a pharmacogenetic test actually helps to improve the outcomes of drug treatment. On top of that, we have guidelines from the Dutch Pharmacogenetics Working Group, but also from international consortia like the Clinical Pharmacogenetics Implementation Consortium and some French and Canadian groups that have all issued guidelines that actually tell physicians and pharmacists exactly if you have a genetic test result, you can use it in this way to tailor the drug treatment for these 30 to 50 different drugs. Also, we had some ideas about potential impact. So interestingly, pharmacogenetic studies over and over show that if you were to test everyone in this room for pharmacogenetic variants, then in 95% of the people here, you would find at least one of these variants for which we have a recommendation. So by contrast to variants for genetic disease, these variants that are involved in drug response, they are not rare, they are common, which builds on the potential impact. And based on these facts, we actually designed a clinical study to test the clinical impact of a pharmacogenomic panel test. And this was the Ubiquitous Pharmacogenomics project. It aimed to make pharmacogenomic panel testing available to all EU citizens, and it received 15 million euro funding from the Horizon 2020 project. And basically, the idea was to do a prospective implementation study in 7 different EU countries and test a pharmacogenomic panel testing strategy combined with the dosing guidelines from the Dutch Pharmacogenetic Working Group. This study was very successful, and the outcome was published last year in February in The Lancet. And we don't have time to go to the details, but here you can see the highlights. And what you can see here is the event rate. So this is the occurrence of clinically relevant adverse drug reactions in the first 12 weeks after the start of a new drug in the controls and in the people who received the pharmacogenomic panel test. And what you can see is that in the people who received the pharmacogenetic panel test, there was a 30% reduced risk for clinically relevant adverse drug reactions. So this is an enormous result. This shows that also a pharmacogenomic panel test actually helps to improve the outcome of drug treatment. And this received an enormous amount of scientific attention. So there were, of course, also comments to the study, but there were also very positive results. And I think this is a review in the Annals of Internal Medicine that very nicely simulates it. So it has a very high clinical impact rating. And the bottom line is that in adults, genotype-guided drug prescribing versus usual care reduced the number of adverse drug reactions. So this is a very good finding. We were very happy with that. And on top of this, and I've come to learn in retrospect that this is maybe even more important, it had huge societal impact. So there was a lot of media coverage, and we even made it to a game show. So this is taken from the German show on ARD. It's called Wer weiß denn sowas? And there was a question on how can you reduce adverse drug events? Is it by covering tablets with a fat film, taking a 2-hour break, or actually do a pharmacogenetic test? And they won 1,500 euros for a 15 million project. So I think it was quite a good thing. And some people said to me, okay, you made it to a game show, you can now stop your career. Are we there then? Absolutely not. And that's why I think it's important to be here. So we need to improve our ability to predict drug response. And I like this comparison with human height. So human height is quite heritable, and when for the first time it was possible to do genome-wide association studies, everybody thought, okay, we're going to solve the genetic component of human height. It didn't work. And 2 years ago, this study was published in meta-analysis where they showed that the polygenic risk score of 12,000 SNPs actually was capable of explaining this genetic comparison. In our EU study, we used 50 variants. So I think there is enormous potential to improve, and we're currently only looking at this tip of the iceberg, and we need to do better. So in fact, we've gone through all these steps from the idea. And we're now quite close to getting to the patient. Actually, this is going to be implemented, but there are some health policy challenges, and there are also some scientific challenges. And what's important here is that recently we started under the umbrella of the 1 million plus genomes project, we started a specific working group 12, focusing on pharmacogenomics. So I think this is a great opportunity. So what are those challenges? And for the sake of time, I will go through them quickly. So we need to expand on the parts of the genome that we include. We need to include people from other ethnicities. So this DPYD test tests for 4 variants. It works perfectly in whites. This has, again, a lot of attraction in Canada. This is a family that originates from India. And this person, Anil Kapoor, actually was tested for 4 variants. Still, he died within a month after starting his cancer treatment. He carried a variant that's quite common in India, but it's not tested for in the Western world. We have opportunities here. So what we currently try to do is we link genomics to mostly pharmacokinetics, predicted enzyme activity. All these processes in between are still largely ignored in pharmacogenomics because we're talking about processes in the liver. There are, of course, enormous opportunities to do this better. So I think they have been discussed, but I want to highlight a couple. So one is polygenic drug response scores. We can use machine learning, long-read sequencing. This one is very interesting. It's related to metabolomics. Why a potato, you may ask? Well, it seems that in a potato contains a substance, solanidine, which is metabolized by an enzyme in the liver that's also responsible for the drug metabolism of 25% of all marketed drugs. So I think we can use it as a very good endophenotype to improve our genetic predictions. So we need to integrate with all these tools, and of course we need to integrate the genetic data with all the stuff that we already know from clinical pharmacology. So we already do therapeutic drug monitoring. We should combine this with our genetic knowledge. What's a nice example is some research that we did. So we looked into this liver enzyme CYP2D6, which is involved in the metabolism of 25% of the drugs. We noticed that with our, at the time when this project started in 2015, state-of-the-art genetic test for CYP2D6 could explain 42% of the variability in CYP2D6 activity. We know that it's highly heritable, so 90% is heritable. But our test was just not good enough, and by using long-read sequencing combined with a neural network, we were able to increase this to almost 80%, so capture almost all genetic variability. And I think this could be a very interesting next step. Another thing is an ongoing project. It's called Safe Polymed, and this project really tries to integrate our knowledge of genomics, clinical pharmacology, but also data from a very large biobank. So FinGen is involved there, and the Estonian biobank and the UK biobank, and use stuff like PBPK modeling to integrate this and to come to integrated recommendations for managing what we call drug-drug gene interaction. And this is work in progress, of course, but I think it's very highly promising. Then we have some policy challenges. So we've shown with our European project that the panel test is useful, but of course we don't have the funding to start testing all EU citizens. So we need to identify which patients actually benefit most. And more importantly, maybe we need to finish up our overall cost-utility analysis of that project. That is still work in progress. There is an issue about reimbursement, so who should cover for all these tests. There is enormous variability between the different EU countries, how this should be done. Training and education of physicians and pharmacists, and also of the general public. I think this is also something that is very important, and there is increasing focus on this, but it should be a lot more. We need a better infrastructure. And what's important here is that we need to harmonize actually which variants we're going to test in a pharmacogenomic test. And this needs to be integrated in the normal workflow. Now it's still something exceptional. It should be just a regular test that a physician can order. And what's also very important is that the results of such a genetic test can be exchanged through the entire healthcare chain. So they should not just stick with the facility that did the test. No, they should be available everywhere, point of care. And finally, and I think this should not be underestimated, and I've illustrated it with the DPYD example, there is really a lot of impact there from regulatory messages, for example, from institutes like EMA. And with that, I would like to thank you for your attention, and I'm happy to take any questions. Thank you.
So what I'm going to talk about is much of the same themes that have been come up over the past couple of talks as well. How to use genetic information for better identify high-risk individuals for diseases or settings where that information is most useful. This is the state of the art when it comes to our example disease, or first example disease. This is cardiovascular disease risk calculation. On the right-hand side, there is the SCORE2 calculator, European pan-European clinical calculator, taking in risk factors for cardiovascular disease and putting us into boxes of low, medium, high, or very high risks. Now what goes into the calculator are the things that we've been known for a long time. Cholesterol levels, blood pressure levels, our smoking behavior, age and sex, and these kind of things. On the left-hand side, there's a Dundee calculator, an analog version of the similar kind of tool that was put together already decades ago. In comes the same things. So not much has happened in terms of our ability to evaluate risks for coronary heart disease, even though the algorithm has refined a bit. This is the other side of the coin. If we look at the diseases, and we can take almost any of the common non-communicable diseases that we have, there's the genetic side of the coin. And for coronary heart disease, the genetic variation explains about a half of our differences in our risks. So that's the heritability, roughly. We've been associating hundreds of genetic variants and genetic loci as risk factors for the disease. We know now that there's common variants that we all share that elevate or lower our risks a bit, but there's rare variants that are rare in the population, but if you happen to have one, they may have a much bigger impact for the individual themselves. So that's the sort of the landscape. We and many others have been trying to combine this information, now putting together the genetic information to develop algorithms or polygenic risk scores together. And a couple of years ago, we utilized one of the earlier incarnations of FinGen data to look at how well we stratify individuals in the most common diseases that we have. There's coronary heart disease, type 2 diabetes, atrial fibrillation, breast cancer, and prostate cancer. And without looking at the details, you see the profiles are pretty much the same for any of the diseases. We do separate or stratify individuals based on genetic information only pretty well in these diseases. For many diseases, we do actually screen for individual genetic variants, at least in specific settings. Breast cancer is the example in this slide. On the left-hand side, we have a number of genes and variants within genes that we know that impact individuals dramatically, or women's risk for breast cancer dramatically. We have sort of a mid-ground of variants, and then we have a lot of the gray ones, the common variants in the population. Even though individually their role is small, taken together, if you happen to get in the nature lottery a lot of them, you end up at the high end of the tail of the polygenic risk, and your risk may be on the same level as on the more dramatic individual variants, or at least almost on the same level. If we ask the question the other way around, if we take 100 breast cancer patients and ask in our FinGen data, how often do we see the rare high impact variants of the carriers, and how often are we at the similar level of polygenic risk of the individual? This is the picture. There's 100 women on the left. You can see that the yellow ones are the ones with the high polygenic risk score, at least on the same level as the average mutations, like CHEK2 there. And the variants that we currently are testing explain only a small proportion of the cases. Now there's still lots of gray, which means that we have work to do in terms of understanding breast cancer. But this is sort of where we are right now in terms of looking at these variants and identifying them. So what we are currently doing as part of a Horizon project, Intervene, is actually testing now a more comprehensive setting of testing for breast cancer risk. For those women who already have the cancer, we screen for the risk, the individual high impact variants, as well as the polygenic risk for these women. And then we utilize this information in the decision on how to screen the healthy relatives of the sisters or daughters of the patient, and test them as well. And this is now integrated as part of the communication in the Helsinki University Hospital clinical genetics lab. But where do all this risk information come from? I already mentioned FinGen. This is sort of a schematic plot of what FinGen is all about. It's a half of 550,000 individuals recruited from Finland for the study, why 550,000? Because we want it to be a little bit bigger than UK Biobank. So that's where the additional 50K came from. Everybody has been genotyped, imputed. We modified the axiom array for our purposes and linked to National Health Register data. Now, the National Health Register data there is a small box, but inside of the box is a really wealth of data from the Nordic-style health registers in Finland. Anything from the lab values that are now centrally collected into one database across the whole country to, say, all cancer screenings and evaluations of the cancer screening, every hospitalization, every prescription drug purchase, as well as the prescription is there since 1995, and so forth and so forth. So it's really a wellness of data that can be used for these type of exercises. It's a public-private partnership where it's really important that we work closely together with industry in terms of developing the cohort and developing the research project itself, the focus areas. And we have 10 Finnish biobanks participating there. There's Finnish taxpayers' money from the Business Finland side in FinGen, as well as now 13 pharma partners working pre-competitively. So everything is shared. All the things are shared within FinGen. Okay, so we can do these type of explorations now in a 550,000 individuals. On the left-hand side, we compared for coronary heart disease. If we take age and sex, which are by far the biggest risk factors for coronary heart disease, if you're a male, if you're getting old, you're in trouble. If you're a female and you're young, you're not in trouble. But then we compared on top of that, what are the risk factors? You can see that polygenic risk score is the biggest additional value-bringing factor there on top, and then putting together with the clinical risk factors gives the best value for this. Now we have algorithms. We have tested them. We showed that they stratify individuals based on their risk. The question is who would benefit most. In our earlier paper, we looked specifically at how often do these clinical risk scores versus genetic risk score provide information about elevated risk for three diseases there: coronary heart disease, type 2 diabetes, and atrial fibrillation. The bar chart there shows that red is that it's elevated polygenic risk, blue is that it's elevated clinical risk, and the purple one shows that both risks are high. And you can see that there is a considerable amount of additional value even on top of the clinical risk factors, particularly in early onset cases. Early onset meaning for coronary heart disease before 55, so type 2 diabetes before 45, and for atrial fibrillation before 60 years. So this is a particular sweet spot where the clinical risk scores are not behaving so well simply because they've been trained with middle-aged individuals. They haven't been so well trained with the younger individuals, and they look at 10-year risks typically. So another way to look at these things, now that we have pooled in Intervene study FinGen and other European cohorts together, we can ask the question this way. We can look at the cumulative incidence over age in different strata. This is type 2 diabetes. We can take some of the recommendations in terms of the screening. Here is now American Diabetes Association recommends that everybody should get screening at the age of 45 for type 2 diabetes risk. Now, if we take the black line there, look at what is the cumulative incidence, the number of cases accumulated at that, or risk accumulated at that time for an average person in Europe. And then we draw a line and see where do you cross that line, the same cumulative risk, if you have a lot of risk alleles for type 2 diabetes. So the blue one shows that you actually cross it at the age of 22. So already at 22, you have a similar accumulated risk for type 2 diabetes that an average European has at the age that American Diabetes Association recommends as the screening age. On the other hand, if you have a lot of protective alleles, you're not crossing the line before 80. And then, I don't know if 80 is something that you still want to carefully look at this. Maybe it is. We are getting older and older. But this is the type of one way to look at the potential for screening there. That's all algorithms. But it's nothing if we cannot communicate the risk to individuals. So we developed a tool a few years back called Cardiocompass to not only tell the risk about the risks of individuals to individuals themselves, but to compare their risk to an average Finn in this case, and show that, hey, you're pretty high up compared to an average Finn. And the competitive person among the Finns really looked at this and say, hey, I don't want to be there. They can also toggle around that if I stop smoking, my risk, a person with similar profile would have a risk like this. We tested this in 7,500 individuals in a project called Gene Risk. What I want to highlight here now is that out of everybody that had high risk, elevated risk, on the level that we say that we recommended that you should contact your doctor, 21% of the individuals who participated in our study, so they were already positively, attitude towards this thing. Only 1% contacted the doctor. So that's where we try to push it one step further. What if we now, instead of simply providing the information and saying go ahead and contact the doctor, what if we do it as simple as possible? So we communicate the risk, then in the follow-up study in a mobile app where they had a button right there to chat with an MD. And this is where we are right now. This is don't tell anybody, this is still unpublished data. So this is sort of the most important thing here. If you have a high risk and you have the button, the chat-based medical doctor there, it's now 36% that do push the button and start the process of lowering the risk. Of course, somebody may do it themselves, without the doctor, but that's so we roughly double or a little bit more than double the number of individuals now who we encourage to do this or get it done there. The second take-home message, that's the good news, what I just said. The bad news is that it's twice as many also for the low-risk individuals. So those that really don't need to contact any doctor are very happy to have the button there and talk with their doctor if we pay the price for that. So that's the sort of the end game, that how do we get the true people? And of course, this has nothing really to do with genetics or genetic risk. This is more behavioral science on how do we get the right people to lower the risk. I'm probably running fairly soon out of my time, so I skip a little bit and just say that from the cancer side of things, there were mentions about the breast cancer screening and how can we utilize these type of tools in breast cancer or colorectal cancer screening. Our nationwide programs are such that everybody is doing the same. For breast cancer, start at 50 until 69 every second year. But again, if we play the game that the high-risk group probably should start earlier, the breast cancer screening, because they are accumulating cases fast. And then comes the sort of maybe ethically more difficult question, what to do with the low-risk women? Should we simply say that don't come, or because there's always going to be cases among them as well? But there is a 24-year difference at the tails of this, so top 1% versus lowest 1% in terms of getting the elevated risk here. Okay, this is an interesting plot because there's nothing there, so let's skip it. Colorectal cancer. So we looked at if a person had a colonoscopy, it was negative. Typically, they are asked to come back in 10 years. We looked at what happens between now and 10 years in terms of who gets colorectal cancer in between, and how does the polygenic risk score stratify individuals. In the top 10%, there's clearly, that's the orange line, there's a lot more cases accumulating over 10 years, and maybe they should come already at 5 years. So these are the type of settings where these type of tools would hopefully be informative as well. Final slide. As a community, genetics community, we've been thinking a lot about the matters from the genetic point of view, how to take these tools into clinics. This was an International Common Disease Alliance, PRS task force, where we created a responsible use of polygenic risk score in the clinic, potential benefit, risks and gaps white paper. Here are the main take-home messages. The clinical utility is still needs to be determined in these cases. It's difficult because it's costly and it's case dependent. We can calculate the risks, throughout the different diseases, but that's case dependent. This is an important point that also we heard in the previous talk. The focus on equity and inclusion is really important. All of these algorithms have typically been trained with white European people, and they work very well for European ancestry individuals. They work relatively well for South Asians or East Asians. They work poorly for African ancestry, particularly from sub-Saharan Africa. So we need to make sure that whatever we are going to implement are going to work on them as well. And then there are other things as well, the integration with recommendations and is really important. Finally, I simply mention the three champions of much of what I presented, Nina Mars, Elisabeth Widén, and Max Tamlander there, as well as the team, Finj and Arno Palotti and Mark Daly, who have been driving forces there. And I'm happy to take any questions if there's time.